Hi, everyone. Thank you for being here. Now, my talk looks very different from this one. I'm an assistant professor in sociology in CDS, and I study social networks. I have some ongoing work with people in public health. My talk today is going to be a little bit about the kinds of methods you can use in through social network analysis to look at health outcomes. So one of the first things to keep in mind is that, one of the first things that network research shows us, that health behaviors tend to cluster within social networks. Now, social networks are the set of relationships that we're embedded in, our friends, our family, our neighbors, all the people we have discussions with, and so on. And we find that health behaviors of all different stripes, smoking, drinking, suicidal ideation, oral health, obesity, exercise, eating behaviors, mental health, all of these tend to cluster within networks, meaning that our friends, people that we're connected to, our friends, our kin, our neighbors, tend to have behaviors that are similar to us, what's known as homophily in networks. Now, the question is, how do we figure this out? How do we measure this, right? And one of the most useful techniques for measuring homophily in social networks are what are called ERGMs, or exponential random graph models. They're statistical models that we can use on sociometric data as well as some ego network data. The idea is that we collect data from a particular context. For example, I'm working with Brenda Heaton and other people. Brenda's recently moved to Utah, but she still has a leg at BU in public housing developments in Boston. When we're asking people, who do you do groceries with? Who do you eat your meals with? Who are your friends in the development? And once we collect these data, we also ask them information on their health, right? When did you last visit a dentist? How would you describe your oral health? And then as a result of this, we're able to look at whether outcomes such as oral health tend to cluster within network neighborhoods. What that means is, our people who are friends, do they tend to have similar kinds of health outcomes? And we, in fact, find that the people who are of superior health, their networks tend to be more homophilous. That actually is really good in some respects, because that tells us that people who are of poorer health, such as who have poorer oral health, actually have good oral health partners and friends. And the next step is to try to leverage this information to create interventions in the field that focus on networks. So traditionally, health-based interventions have focused on individuals, messaging to individuals to try to get them to change their behaviors. But increasingly, it's being recognized that network-based interventions can be highly effective in changing behavior, because rather than trying to convince one individual to change their behavior, we try to target the network and create support systems where, if my friend can do it, I can do it. And if we're trying to change behavior, we collectively try to change behavior, rather than me receiving counter influence from my friends of negative behavior. And so one way to do that, of course, is to conduct an intervention in the field. But prior to doing that, we can often start with what's called agent-based modeling, which is sort of a simulation environment in which we create agents, individuals, they're connected. We replicate the social networks we see out there in the field, create those similar kinds of networks, and then test what happens if we give an incentive, or we create an intervention such as asking doctors to create interventions for groups of interconnected people rather than individuals, and look at the outcomes in that simulated environment. And then that simulation helps us then design better interventions in the field. And I will stop there. Thank you. Reach out to me if you're interested in talking more.